Hi, thank you for watching Podiatry Practice Mastery. I appreciate you showing interest in these videos, and they're coming out weekly, and I hope you have interest in them. Underneath this video, you're going to find some other resources based on the topics we've addressed. Also, we're putting together some group sessions you might be interested in. If you want to have more information of kind of developing and being part of a podiatry community where we talk about practice management ideas, I'd love for you to join us at the next one. The information is underneath this video. Thank you so much. Hello and welcome to Healthy Living. I'm Dr. Donald Pelto, and today I have Mr. Andrew Vieira. He is going into his first year of medical school coming up here, and but for the last couple of years, he's been working as a medical scribe, and we're going to talk a little bit about that. Andrew, thanks for joining the show.
Hey, thanks for having me, Dr. Pelto.
You're welcome. And so you're kind of unique intelligent because you're going to Vanderbilt, unique as in you've been working as a scribe for a number of years, which I think a lot of pre-med students do. But tell me a little bit about your history of being a medical scribe.
So, I mean, one of the big things for me was I didn't really have any family in medicine. So I was looking for an experience that would get me like hands-on clinical experience, or as hands-on as you can get when you don't have any professional training. And what I found was there was this opportunity to scribe in the emergency department at the local hospital where I lived. And when I applied for the position, I was offered a scribe position there. I was trained and I started working in the emergency department. And that was kind of like a big eyes opening. This is really what medicine is like. And I was only in my second year of undergraduate. I was actually just starting my second year of undergrad. So it was a great way for me to get exposure to a whole lot of different fields in medicine, particularly in the ER. It was a great way for me to learn medical terminology, to get experience, to see the lives of doctors hands-on, talk to doctors. So from my perspective as like a student considering medicine, being in pre-med, not really having a background in medicine, it was an easy way to really expose myself to, a number of areas of medicine. And also I was highly motivated. So that kind of also pushed me towards being the kind of employee that they would want, where they were, they would have someone that was really wanting to learn. And then in that way, they would also be a very good scribe. So I did that for several years in the ER. And then I also worked with orthopedics. And I worked also in a sort of urgent care setting. So I have a little bit of wide experience in terms of like, high acuity stuff, and then also just outpatient care and all those kinds of things. So I can kind of speak to each of those areas.
Yeah. So first of all, doing undergrad, graduating 4.0, how much time could you work as a scribe theoretically?
So one of the advantages was I was working for a company that would let you work part-time. And since the ER is 24/7 and the ER I was working at had scribe coverage, meaning like a scribe to work with each doctor all day, every day, they had a lot of flexibility at the hours you could work. So I ended up working like every day on the weekend, or I'd work nights, and I would work 2 or 3 shifts a week. So that was kind of just enough of a thing so that I could focus on my studies while also, getting clinical experience and still doing all the other, huge list of things that medical schools want you to do in terms of volunteering, community service, research, and all that kind of stuff.
Okay. So this video is probably going to go out to some podiatrists, and that's kind of a specialist, very similar to orthopedics, I think.
Yeah.
When should every podiatrist or every orthopedist have a scribe, and how do you determine when you should consider having a scribe?
Good question. I think there are certain like red flags, I think maybe for a doctor for themselves that they could decide for themselves. And this might be the situation where I would want to scribe. And I think those situations can be, one, I'm spending a lot of hours after my day, working on charting and notes. 2, that's really affecting my lifestyle. Like first off, not only is the time is it consuming, but it's also kind of wearing me down, burning me out in a certain, way. There's actually studies by the that have shown decreased burnout by having scribes. So if those are kind of issues for the physician. Also, productivity, sometimes if the doctor is one, that stops after every patient and does their note taking, the documentation, by having a scribe in the room, they no longer have to do that. And accuracy. A well-trained scribe is probably going to be more accurate than your memory is if you're documenting on a patient you saw 8 hours ago. So there's also a medical legal sort of benefit to that as well. If you have a really well-trained scribe that can actually document very accurately for you what you specifically want. And then lastly, you can have someone that tailors your documentation to the way you want it. I worked with maybe over 50 or 60 doctors. Each one had their own expectation of, I want this specific detail in here. I want this wording this way. And I was able to tailor the charting to the way they wanted it. So looking at that way, sometimes people see it as a way to relieve their workload, or sometimes people see it as a way to be more productive. And I think particularly for podiatry, it's similar to the orthopedic setting. The doctor I worked for, the big thing for him was decreasing his workload. He was staying 3 or 4 hours after, clinic, working on notes and leaving 7 to 8 p.m. from the office when he was done seeing patients at 4:35. And that was a big thing. He said, oh, I was never going back. That's the big thing I always heard. I never going back. Once I have a scribe, never going back. I always want a scribe. So I think, and he was also very hesitant about it, to be fair. He was the one doctor in the orthopedic practice that did not want a scribe at first. But after he had a taste of it, he was like, no, I really want this. So my experience has been whenever someone, starts having a scribe that does a good job for them, they recognize the value of it and they don't really want to go back to doing the documentation and the sort of, the job of the doctor is to not put in information. It's to treat the patient. So, outsource that to someone who's good at it.
Yeah. And now when a lot of us, we think of that, wouldn't that be just great if you could treat patients and have everything else kind of be done for you?
Right.
How much time does that, like a lot of us, I think we just get overwhelmed with thinking, gosh, it's going to take so much time. They're going to make so many errors. I'm going to have to review all their charts. How much time realistically does it take to train someone? Let's say someone that has no training and get them trained.
It's a good question. I think it depends on the specialty. When I went to the emergency department, I worked for a company that trained me. I would say that their training of me was not really close to what I needed in terms of training in the clinical area of actually being in the emergency department. And so then a lot of times it falls into, and I was a trainer, I was a chief scribe actually. I trained many scribes. I established an ER program of scribes.
So you go in, it was the doctor, you and another trainee. Okay.
Exactly. I would actually, direct scribes. I would actually train them before, and then on the floor of the ER or in the orthopedic practice, I would follow them around and, guide them and also look over their work. And what I found was, for me particularly, training a scribe is dependent on the quality of the person you get. Now that's the benefit. It's a universally symbiotic relationship for a scribe and a doctor if you get the right kind of person. For me, motivated pre-med student, I want to learn. I want to, this is my future. Like everything I'm doing, everything I'm documenting is also a detail that I'm trying to, put into my mind as not only just like a memorization thing, but also as a critical thinking, like how does it actually apply to what I want to do in my future? So when you get those two things combining, you'll find that the training process can be really rewarding. If you're one of those physicians that likes to teach your patients, you end up teaching the scribe alongside. And also you find that person will pick up things very quickly. You won't necessarily have to manually tell everything. I kind of would pick up on patterns of the doctors, pick on their preferences, look at their old notes. That was a big thing I could do. I would look at their old charting and kind of pick out how they documented. I would say if you got a brand new person that was highly motivated, intelligent, someone that wants to go to PA school, podiatry school, medical school, that you can tell is someone that's really excited about that role, I would say 3 months, you should be pretty comfortable where you're not really looking over their notes too intensely if that's something that you're very concerned about. And then probably around the 6-month mark, you're like bonded at the hip and, that person can already document your note without even you like having to say anything specifically to them. They can just look at your physical exam and identify the abnormal findings and all those kinds of things. I actually had doctors with me that were very good at, I could see them. For example, I worked with an orthopedist who did shoulders, and I could see when they were palpating the, proximal biceps tendon, or I could see when they were palpating the subacromial bursa, and when the patient was complaining of pain, he wouldn't even need to verbalize any more tenderness to me. I could just document tenderness in that area. But that depends on the relationship with the scribe and the doctor. Each person has their preference. So
did you so were there computers in the room so you were typing as they were doing it, or did you leave the room and then do it?
So depending on the situation, in the orthopedic practice, initially I had a laptop, and I would come into the room and I would document while we were seeing the patient. And then they transferred to a new system that used iPads that was very pro efficiency, very good at kind of moving things very quickly. And then it became more of like sort of, rather than a data entry click, like typing away, it was more like a clicking based system where it was like, positive sort of specific tests or tenderness and range of motion degrees and those kinds of things that you would just click on. But regardless of the EMR, I was able to work with whatever system I needed. Sometimes it was very, typed out. And some of the doctors wanted that. Some doctors want a very typed out history. And others want a very sort of bare bones, just get me to the information I need. And either way, the scribe should be able to adapt to what is needed. And I never found an issue. There was a doctor that I was like, oh, this is just too much to work with, or a system that was too impossible to handle.
Yeah. And so let's talk specifically that 6 month period. Let's say
Hmm.
you're finishing residency, you're in practice 3, 4, 5 years, you start to get
Yeah.
really busy. You're noticing it's taken an hour or two to do notes afterwards, or you're just feeling you need too much time, and you have a very successful practice. Initially,
Right.
do you shadow the doctor initially, or do you spend time and they go through all these scenarios? How does that
Hmm.
work practically?
So depends on which process you want to go by. So if you want to hire a scribe company, they will provide the training. They will provide the scribes for you. They'll give you someone that's already, like, let's say you're a podiatrist. They will provide you a team leader that's already worked in podiatry and that will train newcomers in to
Okay.
work in that area. That's nice. It's very hands off in certain ways. It also, though, depends on the quality of the company that's providing that, you know, and depends on the quality of the person they provide to you. So,
Hmm.
you know, with large companies, you never know necessarily what you're going to get. I
Yeah.
did that part. You know, I worked for a large company, and then I also did independently where I worked directly for an orthopedic practice. When I worked directly, I didn't have any training. So I trained myself. Thankfully, I had already done ER, so I kind of knew what I was getting into. So I just kind of read notes by the orthopedist and then shadowed the orthopedist and then slowly built up, meaning like maybe 1 out of every 5 patients, I would do the chart on it. And then the
Okay.
doctor would take a long time and really go through it, tell me, here's what I did, here's what I missed, here's what you need to improve. And then I would speed up 1 every 3, 1 every 2, you
Okay.
know, and then until I was actually up to speed, and then he was comfortable with all my note taking. Um, and that's generally the kind of way you want to take it. You definitely need to have a certain degree of oversight, particularly in the beginning. And it is an investment. You're investing in that person, and that person's also, and you're investing in the fact that that person's going to stick around for a while. So there needs to be a very good, like, mutual bond. You want to have a good relationship with that scribe.
Yeah. Yeah. Like you said,
I've always
they're
found
attached at your
that
hip.
attached at the hip, exactly. Like, I find that it's always worked best when the doctor is very open to communicating with the scribe. When the scribe asks you a question, generally, if it's a good scribe, they're knowing that they're respecting your time, but it's a question that's important to not only that moment, but future. Like, I don't understand this exam finding that you did. Can you please explain it to me? Now, from that moment on, they will always know what that exam finding means. So it's a bit of an investment on the front, which can take a little bit of effort, but on the long run, you get a big benefit.
Yeah. Now, as a scribe, I know in our EMR we have a lot of templates,
Hmm.
macros we call them. Would you could either make them for them, or you could, because you would want to use whatever the high tech methods of the EMR, right, to make it more
Right.
efficient to you. If you're typing the same thing over and over, you make templates. You guys do all that stuff, right?
Exactly. Again, preference to the doctor. Some doctors hate templates, macros. Some love them. Um, I worked with doctors in the office where in the orthopedic practice. They changed EMRs, and the new EMR had a lot of template-based systems that you could use for efficiency. And I just went in and created templates for everything they wanted. I had template surgery orders for common surgeries, template physical exams, template plans, template all kinds of template documentation that I could just click on and put in as macros and could fill out. And it got to the point where it's so efficient that I could put in the physical therapy orders, MRI orders, and even other kinds of orders. So there's other benefits beyond just documentation. There's actually
Yeah.
ordering, completing things in the room for the patient rather than passing it along to like a nurse. So templating and macros is definitely something that the scribe, if they're very good at knowing how you like your documentation, you might not even have to create macros. You just say, hey, I commonly see this kind of thing, plantar fasciitis. I assume is something super common you
Yep.
see.
All the time.
You know, you see it all the time. You see it commonly. You have a certain treatment plan every time.
Yep.
You know, there's
Hmm.
probably a macro that you can map for it. But let's say you just switch to an EMR. That scribe already, if it's been working with you for a while, already knows exactly what that plan is. Can probably type something up for you. You look it over, edit it,
Perfect.
and now you've got a macro for the rest of the time you work. And even when the next scribe comes in, the learning process is a lot easier because now when you switch out, the scribes aren't usually permanent positions. Like for me, I went on to med school. Um, the next person that comes in already has templates to look over. And so there's actually sort of like a long-term benefit from that as well.
Yeah. Now, sometimes, what about the awkward moments? I know I have sometimes with my patients, they're challenging patients. Do they
Right.
sometimes, oh, just don't come in this time? Or if there's like a couple of patients cancel and they're just kind of sitting around, are you sitting right next to them, or do you have your own office? Or so those two kind of awkward situations.
It depends on the relationship of the scribe with the doctor. I had doctors that told me like, please avoid speaking to me as much as possible. I'm focused. Message me on like the EMR itself if you have something to tell me or ask you. And other ones that just like to joke around, want me to sit next to them, like want me to converse, talk, chat. So it kind of depends on the relationship of the
Okay.
doctor and the scribe. But you can set it up any way you want. I worked in. We actually not only do we switch EMRs to the orthopedic office, practice, but we also switched offices. And the first one, I actually sat in the doctor's office with them. And so we, between patients, chat about exam findings, chat about whatever the latest news, or, and that was the kind of relationship I had with him. I really enjoyed that, but that's not necessarily for everyone. And then also when we moved to the new office, I worked with other doctors who were less, chatty. And I actually had my own little office space. So whenever we'd be done seeing patients, I would be able to ask the doctor questions when leaving the room, like, hey, I missed these findings. What was this? What did you mean when you said this? And then I would go sit down at my desk and type out the rest of the note until we went and see the next patient. So you can kind of tailor it to whichever way you want. I think you might have also been talking about sort of awkward moments with patients. There are patients who aren't necessarily comfortable with having a scribe in the room, but I would say surprisingly rare, particularly dependent on the way you present the scribe. If you present the scribe as someone that's keeping you off the computer, like, hey, I want to give all my attention to you as my patient. My goal is, if I'm working on the computer, I just don't feel like I'm giving you the attention you deserve, and presenting it that way. Also presenting it as like, this person's probably like a future medical student, someone that's, really wanting to learn. And it also introducing was a big thing, the doctors that wouldn't introduce me to the patient would kind of get weirded out by the fact that I was just standing there watching them. And making a welcoming environment, and having the scribe also be someone that's welcoming to the patient and introducing themselves. Now, there always will be the occasional patient that's going to say, please, I'd rather not have anyone.
Yeah. And you probably you're smart enough to notice, this is going to be a challenging, certain, I'm just going to excuse myself, or or the doctor will just say, could you just give me some privacy for this one?
Exactly. And then, or even before I go in the room, sometimes you'll have a patient that is like, this is someone that prefers their privacy. Why don't you just sit out this one and I'll come back and tell you what you need to know.
Okay. I was going to say, and then does the doctor do the note, or he just verbalizes it to you?
Whatever the doctor prefers, sometimes they can just verbalize it to me. Sometimes they prefer to do on their own. Either way, that might be 1 out of 30 patients you see at that day. So that's not really, that's not a common thing. And it's also not something that's really going to add to the doctor's workload in any certain, significant amount.
Yeah. So now you're going to be going to medical school, so you can talk about this. Let's talk about in terms of how much do we have to pay a good scribe? I know you probably think you should have earned a lot more. What's fair? Do you start low and build? Is it like more than a medical assistant, or is it around that amount?
This is where you get into like a little bit of the nitty gritty. If you hire a scribe company, I know that there's a certain amount that they will charge you per hour for the service that the scribe provides. So when I was working for a scribe company, I later found out that they were charging about $20 an hour for my services there.
Okay.
Now, here's the thing. In the ER where I worked, there was a big variability in the quality of the scribing, and the quality of the scribes, and the quality of the management of, making sure that the scribes were really good. One of the reasons I left the ER setting was because I had actually gotten to a position where the chief scribe that I was working for, and then the management above me, I didn't feel like was giving me the right support I wanted and helping me establish the kind of team I wanted to establish. And so when I felt that I was thinking to myself, okay, well, my services are worth a certain amount, I don't feel like I'm getting enough support from the company, maybe I can just go to a private practice and work individually. And so I kind of had that $20 an hour kind of thing in my head, which is a little bit more than the medical assistant I think typically would make.
Yep, it is.
But also I didn't necessarily come in with no experience. I'd already been a chief scribe, I'd already managed scribes, I had a proven past. So I would say when I was working in a private practice setting, they were hiring scribes for $13 to $16 an hour typically. And then if you had someone particularly good that you thought, oh, this person could be a leader for other scribes, if you have a practice of 5 to 6 doctors, this person can train other people, this person can benefit in other ways, I want to hold on to them, you might offer them more. And that's kind of what happened to me. I became a sort of clinical leader in my orthopedic practice, and I made a little bit more than the other scribes. But, at most I was making $19 an hour.
Yeah, no, that makes perfect sense. Can having a scribe have you not need a medical assistant? Like there are I know it sounds funny, but would you like go get DME or go get product or go, like, do you like run and do stuff for the doctor? Get an injection, a cortisone injection, stuff like that.
Exactly. That was something that we actually really moved to. I was a big proponent of that obviously in the ER you can't. As a scribe, you're not allowed to do anything clinical in an ER setting. There's a lot of hospital protocol. But at least in Florida, where I was living, there's no licensure requirements, I believe, for medical assistants. But regardless, you can send your scribe for medical assisting licensure if required. And that person can serve as both a medical assistant and a scribe. So I definitely did those kinds of things. I fitted patients for DMEs. I got them their physical therapy protocol orders. We had rotator cuff repair protocols for physical therapy. I would hand them out, give them their MRI orders. I would go grab cortisone injections. I would draw up injections. I would set up ultrasound for ultrasound guided injections.
Yep.
So not only was I serving as a documentation, I was also serving as an assistant, which was fantastic because let's say that the doctor's in the room, seeing the patient. That person that's doing all those processes, the doctor says, hey, I'm going to send you to physical therapy. Well, the scribe/MA is already filling out that physical therapy order. They already know what the physical therapy order is going to be. They look at the surgery order. Next thing, I'm going to give you a steroid injection to your shoulder. They already know how much to draw up. They're already doing it. There's no telephone game. That was a lot of the problem we had before, where it was like, doctor would tell a nurse outside the door, and then the nurse would tell someone else, or tell another MA. And by the time they got there, there was a miscommunication. The wrong thing was bought. The doctor's already in another patient room, and now how is that nurse going to talk to the doctor without interrupting the patient, the other encounter? So what we actually established was a dual scribe MA process where we had two people working with one doctor and they would alternate seeing patients. So I would go in the room, see the patient, document the note, and then follow through, set up an injection, give them their physical therapy order, put their MRI order in, walk them to checkout, make sure their DME fitted them appropriately. So the doctor could already kind of move their mind to the next patient and not have to worry that is that patient being taken care of. So that is definitely a system you can do. There's a lot of flexibility. There's not really a lot of hard, fast rules about this. That was a system that we found in that orthopedic practice worked really well and made the doctors way happier and improved efficiency. We actually probably started seeing, I could argue maybe like 10 to 15% more patient volume per day, just because the doctor wasn't, getting interrupted. And also the doctor was happier because they're not getting interrupted and they know someone's following through exactly how they want it. And the patient already has a rapport with the scribe. Awesome. They've already seen the scribe in the room.
I think that's a true tale to even, for $20 an hour, if that's a 10-hour day, that's one extra patient so
exactly.
It's really
that was the mentality of the physician I worked for. The physician I worked for, sorry to interrupt you, but the physician I worked for, that was his mentality. He's like, well, if I can see one more patient a day, I'm paying for you, or if I can see two more patients. And I was probably at the end, once we had gotten things flowing and optimized the EMR, I was probably seeing, 5 or 6 more patients a day with him than he normally would. And particularly because, doctors a lot of times don't want to deal with the computer IT things. So there's maybe a lot of efficiencies that someone who's motivated to make the system better will find out and work on that the doctor would never have time to do. And that's what happened with me.
Yeah.
I learned about the EMR on my own, and then I started implementing efficiencies and improvements that the doctor would never have done on their own because their focus is seeing the patient. My focus is making my job a little easier, my life a little easier.
It made your job easier. Yep.
It makes my job easier. So it seemed to work really nicely where everything kind of, the motivations and incentives for everyone kind of lined up really well. My incentive to learn and to make my life easier and to be more efficient lined up with the doctor's desire to have someone complete their note taking, to have someone that, was by their side and can understand what they wanted to do without having to be overly worked and burnt out.
Yeah. Now, what happens, Andrew, if you got sick, if you go on vacation, things like that? Does the doctor still know how to do notes? Like, do they just get super behind and you come back and he's like so happy?
It can be that way if you're not set up correctly. I think, ideally you want to have some degree of redundancy. And right before I left the orthopedic practice I was working at, that was what we were implementing. We had a group of scribes who were pre-med students or pre-PA students. And then we ended up actually getting the MAs that were already in the office and we started training them to be scribes. So we kind of created this hybrid position across all of them. And so even if you had someone that maybe wasn't the most proficient as scribe, at least on one day they could come and take those notes. Those notes would not be signed. And then the official scribe can come back in and, take a look and make sure that they're all accurate. Or you can have multiple people that can come kind of alternate in. You also will always want to have, the doctor being capable of note taking. I was a big proponent of that. I would say there were maybe like a couple of doctors here and there that kind of were like, nope, now I don't need to do this. I never need to look at this again. When you come back the next day, you just do all the notes. Or you can take it home with you and I'll pay you overtime. But it depends on the desire of the doctor. But we definitely created redundancies where there were people that could fill in on days off. And I needed that. I needed to interview for med school. I needed to do things. I needed to study for my MCAT. So
well, I guess it makes sense as I'm thinking about it. It's the same when we have 1 or 2 MAs call out sick. You make it work. And I think there are certain days you just kind of make it. It would be the same thing for you guys. You just make it work.
Yeah, one bad day of, maybe the doctor having to do half their notes because they have someone that's not as proficient, or however it works, however that day might happen, is still worth the 300 other days where you got, a
Yeah.
ton of relief.
Now, as we kind of finish up, the last question, I know there's some programs out there doing virtual. I've seen one where you bring a
Hmm.
mini iPad in called Hey Rach, a couple of different ones. Virtual versus actual person. Any thoughts? Have you had any experience, or what are your thoughts on it being a scribe for this long?
I've never been I never worked as a virtual scribe. I can give you the pros and cons real quick. Pros of virtual scribe: that person's going to already know their things. It's going to be someone that's already trained. They're already going to know podiatry. You probably less, working one-on-one with that person. They just come virtually into the room. They document the note's done. Cons: they don't know your personal preferences. You're going to get a different scribe every time. There's no guarantee of the quality of that scribe. Maybe some of those virtual scribes might be more of a professional scribe, versus someone that's maybe more motivated, like a pre-med student.
Yeah.
The pros of an in-person scribe: that person knows you personally, knows your preferences personally, works with you on a day-to-day basis, knows when to stay out of your hair, or when to, tell you something's going on. They even know, in the ER, I would even identify findings on lab results and notify the physician about lab results when, because I
Okay.
knew the doctors wanted me to tell them about lab results that had come back. You get that sort of rapport. And also, a lot of the doctors I work with liked seeing me grow. Like, they enjoyed seeing me, learn their work, learn what they did, and also liked seeing how I applied that to my applications and going to med school and seeing me grow. So that's more of like an emotional sort of side of
Mm-hmm.
things, but
Mm-hmm.
that's
Yeah.
definitely one of the pros. The cons is you have to invest more. That person is not going to be necessarily trained in your area. You'll have to spend more one-on-one time with them. You're going to have to invest more time. It's going to take them longer to get up to speed. So the long-term benefit's there. But the short term is definitely more work for, I think, an in-person scribe.
Yeah. Cool. Well, Andrew, thank you so much for answering. I think we covered a lot of ground here. And any
Yeah.
last minute things that you were kind of thinking about that you wanted to tell me, or ideas about scribes?
I highly encourage any doctor who's a little frustrated, even just a little bit frustrated with the fact that they're not being able to see the number of patients they want to see. They're on the computer when they're talking to their patients. They're spending lots of hours after work, on note taking. I've worked with doctors who are very particular about their note taking, that were very hesitant about letting someone else do
Mm-hmm.
that. I would still encourage, give it a try. Try at least once, with a scribe. If you can, have someone shadow that's already been scribing, just to get a feel for what it would feel like. And I think you'll be pleasantly surprised, because I've had so many physicians who were, very negative on the idea of having someone else do their note
Mm-hmm.
taking. And by the end of it, were, extremely happy and saying that they could never go back to, the way they worked before.
Great. Well, thank you so much, Andrew. Great tips, and I think everyone will like it.
Thanks for having me, Dr. Pelto. It's been a pleasure.